Hello friends, good morning, hope you're doing well. So today I'm going to do a video presentation on how I do over the top decompression. I am Dr. Ankit Madharia. I am an orthopedic spine surgeon from Raipur, Chhattisgarh. So let's just get started. Whenever we talk about over the top decompression in endoscopic spine surgery is a technique to do opposite side decompression of interlaminar through the interlaminar window. In this case, we have to open up the interlaminar window so that we are able to access to the opposite side. The first step in doing an over the top decompression is doing the bony preparations. Bony preparations involve removing the base of spinous process and removing the undersurface of the lamina till you reach the lateral recess on the opposite side. Then the second step being the flavectomy, removing the ligamentum flavum on ipsilateral side first, doing decompression on our side first and then going to the opposite side. And the third step being the lateral recess decompression. What I mean by lateral recess decompression is removing every soft tissue from the lateral aspect of the nerve root on the opposite side. Okay, so we'll go through a video which will show you each step in detail and I'll do a commentary on each steps that follows. So this is a patient in which we have operated from the left side. We entered the spinal canal from the left side of the patient. I usually dock at the interlaminar window at the laminospinal junction, so you can see my endoscope docking right over here. And I have started to burr on ipsilateral side and I have burred out the ipsilateral lamina till I have reached the superior margin of the attachment of ligamentum flavum. So in this video, as you can see, I am just burring out the lamina and the ipsilateral inferior articular process till I reach the upper margin of ligamentum flavum. And as I reach there, I will slightly detach it, and before completely removing the ligamentum flavum, I should focus on doing the bone work for the contralateral side. So I'll start by removing the base of spinous process. I just incline my endoscopic the whole sheet towards myself to aim at the base of spinous process, and I start removing the bone using a high speed burr from the base of spinous process. Now during this whole process the ligamentum flavum should stay intact and you should work from deep to superficial layer, so that even if your burr slips out, it slips superficially and not deep. So don't work from top to bottom, work from bottom to the top and away from the neural elements whenever you are working with a high speed burr, so that you stay safe. What I am doing right over here is I am removing the base of spinous process, and as I remove the base of spinous process, this is a to and fro movement. Just you can visualize the muscles on the opposite side are seen now. So we are just removing the base of spinous process so that we can access the lamina on the opposite side. I use a protected oval burr to do all this bone work, and you can see how beautifully you can visualize, and you need to keep your blood pressure low, ideally 90/60, so that you don't have lot of bone ooze in this process. I am working on the undersurface of spinous process and lamina, and now I have started to go on the opposite side. So this part is the midline and I am started to going on the opposite side right now. What I do is I detach this ligamentum flavum first and I work between the ligamentum flavum and this bone. This is the opposite side lamina. So I'll just detach this ligamentum flavum and use this ligamentum flavum as a protection against any injury to our neural elements. So I'll just work on top of ligamentum flavum, and this is the lateral surface of the opposite lamina where it ends, and this is the inferior articular process inner side. So I'll work on the inner aspect of inferior articular process on the opposite side as well, and just detach the ligamentum flavum from the bone, and then I can work on the lamina on the opposite side, and this is totally working on under surface of the lamina. Now it does not matter whether you are using a stenoscope or normal endoscope, but I prefer to use a stenoscope because it gives me it allows me to use larger instruments and the work is quite fast when using a stenoscope. Now at this level, when we have completed our bone work, we can start removing the ligamentum flavum on ipsilateral side, and once you are done that, you have decompressed the ipsilateral side. You can see this is your L5 nerve root, this is your thecal sac, and now you can focus on removing the ligamentum flavum from midline. So this is the ligamentum flavum on the midline and the opposite side. What I prefer to do is I try to pull it out, but I also like to cut it piecemeal and remove it bit by bit, so that the I can see all adhesions if there are any. You can see there are some bands of adhesions sticking out from the dura to the ligamentum flavum, and if we take it out piecemeal, it is easier to detach it. Now I have reached the lateral border of thecal sac on the opposite side, and now the orientation has changed little bit, that I am facing my endoscope towards the foot side. So what you see it on the top is towards the lower part of the patient or caudal part, and towards the 6 o'clock is cranial right now. I have rotated the endoscope so that I can see the tip of my working instrument. If I put my endoscope in straight line, I cannot see the tip. So I need to rotate it to see on the opposite side. Also, what happens with rotation is the lens of the endoscope goes much more medially as I rotate. If I keep it towards me, it will be towards much more towards on my side, but as I rotate, it moves 2 to 3 millimeters on that side, on the opposite side, and I can see much more part. Now as I am removing the ligamentum flavum from there, you can see there is a bleeder, and the problem with these bleeders is you are not sure whether you are ablating the nerve or vessels. So I use this technique. I use a nerve root retractor to retract the opposite side traversing route towards me, and then I can very easily ablate all the blood vessels on that lateral recess, and these are very notorious to cause lots of bleeding, and people get lost while doing over the top decompression because there is lot of oozing from the opposite lateral recess. So once you have done that, you can remove the fat from there so that you can easily visualize that L5 nerve root on the opposite side. And I am just using a grasper to remove fat, and before removing fat you should not work, because if you cannot see your nerve root, the work becomes very risky and difficult. So once the fat is removed, I can just see this is the L5 nerve root on the opposite side, and now my work remains to just remove that ligamentum flavum from the dorsal and the lateral surface of that nerve root. So I'll use a regular kerrison to go in there and just cut it out piecemeal. I can also use that kerrison to retract nerve root towards me and work on the lateral wall of that lateral recess, to just use it as a retractor as well as to cut the ligamentum flavum, and work becomes very easy when you have a good kerrison punches. So use good quality instrument in this region, and you can see our nerve root is already quite free, and our kerrison is easily able to go towards the opposite lateral recess and remove the ligamentum flavum from there. I always prefer to remove ligamentum flavum from cranial to caudal, because cranially our nerve root has not already exited the thecal sac, so it is quite safer. But when you start working caudally, it is risky. Now again we can achieve hemostasis, or we can check the decompression by using a nerve root retractor, and we can ablate the surface of disc. I usually prefer to ablate the disc surface so that theoretically I eliminate the chances of having back pain after that, because I think I ablate the sinovertebral nerves on the surface of the disc, and that will help me to reduce the post-operative back pain, or if there was pre-existing back pain, that goes away theoretically. Okay, so I always do that so that it reduces the chance of post-op back pain. And then there are some osteophytes on the inner surface of superior articular process over here. Now removing that with a kerrison is difficult, so I use a tube sheath punch and a nerve root retractor. So I will put a nerve root retractor so that nerve is retracted and safe, and I can insert a tube sheath punch to remove those osteophytes from the inner surface of superior articular process. So this step future proves this surgery that this patient will never ever have any decompression in the future, and this region becomes completely free of anything. And this is the end point of surgery, where you can see the nerve root on the opposite side is completely decompressed, nerve root on ipsilateral side is completely decompressed, and thecal sac is completely free of any compression. So this is how your decompression should look at the end point, where both the lateral recesses are completely free. Now there comes a scenario in upper level, like in this right L3 L4 level, wherein while we are doing decompression, our kerrison may not be able to reach the lateral wall of thecal sac because the nerve root is there. So in this situation, it becomes very difficult and dangerous. So what I employ is I use a nerve root retractor to retract that nerve root with the thecal sac towards my side and put a tube sheath punch through it. When I do this, it becomes very safe, and I always start from cranial to caudal. So this is cranial and lower side is caudal, and this is a L3 L4 level done from the right side. So I can easily do this work. I can remove the ligamentum flavum on the opposite lateral recess by using a nerve root retractor and a tube sheath punch, and I can also use a cautery very safely to ablate the disc on the opposite side, ablate the lateral recess on the opposite side. Now we have retreated the cannula to see the lower surface, and you can see I can use a nerve root retractor to see the nerve root, but there is some remnant of ligamentum flavum still there. Now using a Kerrison is risky over there because it will compress the nerve root. So I use a tube sheath punch through a nerve root retractor, and I just chop off those remaining part of ligamentum flavum that are overhanging that neural canal on the lateral surface. So as you can see, this is very safe, and using a tube sheath punch allows us to do fine tuning of that decompression on the lateral recess. And this is what you can see after removing the lateral ligamentum flavum. This lateral recess on both the sides are completely free. I was doing a fusion in this case, so ipsilaterally I have removed the facet, but on the contralateral lateral recess decompression has been adequately done. This is the ipsilateral root, this is contralateral root, and very good decompression of both the nerve roots has been achieved in this case. So as you can see, the over the top decompression is not that difficult, and I have some take home message for you, that plan and execute bone work before opening up the ligamentum flavum. This is because you need to be safe. The point of doing an endoscopic spine surgery is you need to focus on safety of the patient. So do not work on ligamentum flavum before you have planned your over the top bone work. Approach from proximal to distal. Why I say that? Because proximally the nerve roots is intrathecal. So the chances of damaging or biting that nerve root is very less, and when you work from proximal to distal, and as you open up space on proximally, you can easily retract that nerve root towards yourself to work on that. Always achieve good hemostasis. If you cannot see, you cannot work. So before having hemostasis, do not proceed, and you must have correct tools and you must use correct techniques to make your work easy, because I have seen many people who struggle with over the top decompression because they don't have good burr, they don't have good nerve root retractor, or they don't have good cautery. So having good tools is 80% work done, and then only 20% is left for technique. So you must have very good tools. If you don't have good tools, even the best of the surgeons will struggle. Thank you so much for listening to us, and this video has been recorded for Spinoscope conference held in 2024 August 2 to 3rd in Hyderabad, and hope to see you all there. Thank you.